Thanks everyone for joining the Prostate Cancer Lab. Today we have a special guest. He's a member and he is an expert in bipolar androgen therapy. He's an advanced prostate cancer patient and has really chartered new ground in terms of knowledge around bipolar androgen therapy. There's a lot of interest in bipolar androgen therapy from many of our patients that join, and Russ is truly an expert, and he's brought expert physicians to speak to us. Just recently we had Emmanuel Antonaraka speak, and that was compliments of Russ. But Russ has a wealth of knowledge, and I know that you're going to get a lot from this session. So Russ, take it from here.
All right, thank you. I share my screen here. Can everybody see my screen?
Working. Yes.
Okay. So first, a little about me. Just very quickly for those who don't know, I'm Gleason 9 as diagnosed 5 years ago, almost a day. T3C N1M0, and I'm still hormone sensitive. First, what is prostate cancer? Prostate cancer, well, it has four main types of cells. You can divide it up into different cell types. We know 200 different cell types, over 200. And with the mutations, there's got to be thousands or millions or billions total, different varieties. But we essentially can bin them into four different categories. So you have category A, HSV, the androgen sensitive ones, category B. And that's those can be treated by ADT pretty simply, and that's a conventional technique that doctors use. Then you get the androgen sensitive ones, the castrate resistant ones. They upregulate or mutate their ARs so they can be more efficient, get DHT a little easier. And what you can do with ADT, you can add in Xtandi or darolutamide, and that's going to lower the bar and make it harder for those guys to live. So it lowers the bar of testosterone or androgens. And those guys have to upregulate their androgen receptors even more, which they will do. And then you have category C, that's androgen sensitive prostate cancer cells, and they can produce it internally. They require DHT, but they can produce it internally. And that's where Zytiga comes in. Zytiga can block that internal production through CYP17. They can also potentially, we think they can produce DHT from other androgens instead of testosterone. They can produce DHEA, DHEAS, which comes out of DHEA, and androstenedione. And again, Zytiga blocks all those, but the rub is B, the category B, Xtandi or darolutamide will block those, take the bar down, the threshold down. But eventually the upregulation of ARs is going to be high enough to get by that. And CRPC cells, androgen sensitive ones in category C, you can block those with Zytiga, but eventually cancer is those cells are going to die off, but then the Bs and the Ds are going to predominate. The D are very hard to control. They're androgen insensitive, and that doesn't control those. I don't know if we're going to have to use radiation. Hopefully we don't get to that point. That's a bad point when the Ds start to grow. So now the typical change from HSPC to CRPC, and doctors practice ADT, but the typical change occurs in about 1 to 4 years from HSPC to CRPC. They practice the ADT, and some guys last only 6 months on it. Some guys last for 4 years. Some guys last for over 10 years. Great, but there's no real predicting that I know of. We don't know who's going to last longer. So 6 months seems to be the maximum time that I'd want to be on ADT. I was on it for 4.5 months. Oh, and something important here. Oh, shoot. Oh, I back up on this. There we go. Okay. If you are CRPC, we're seeing in trials that you could potentially reset the sensitivity back to hormone sensitive levels where Xtandi is going to work, or darolutamide, or possibly even just ADT. And that's using BAT. BAT has two parts to it, two main parts. First part is you take your androgens to very high levels, and they're called super physiological androgens, or SPA. And really, we're talking DHT here. Testosterone does a lot of the work too through the membrane androgen receptors, but DHT works through the intracellular androgen receptors and eventually goes to the nuclear androgen receptors. It does most of the work here with it. So a lot of times what researchers do, they look at R181, 1881, or DHT itself, and determine R1881 is very similar to DHT, but it doesn't convert into estrogens. There's no converse, so it's very clean. And there's a few differences in half-life. DHT has a longer half-life. Researchers use that a lot to determine what's going to happen to cells when they introduce DHT or androgens. So then, so when we increase our DHT levels, we increase DNA double-strand breaks, and one double-strand break can cause, if it's unrepaired, can cause apoptosis in a cell. Cell is going to carry, or senescence, go into a senescent state to prevent itself from committing suicide, and then eventually, well, hopefully we can take care of it at some point in the future when it comes out of hibernation. But if we, we might think, okay, well, we could just do the SPA continuously. And I did that for 2 years, actually, and it worked well for 2 years. But at some point in time, the androgen sensitive cells, the hormone sensitive HSPC cells, are going to start to dominate. They're growing and they're going to dominate. And I think that's what happened to me. And my PSA started to rise a little bit. And we'll get to a chart later and we can see that. But before that can happen in BAT, we go to another step. We take step 2, we go to ADT. And that requires, as you can see in the chart down here, this is part 1, very high androgens. And then actually what I used here was a 1-day half-life, and that is what propionate gives you, testosterone propionate. So we can take our androgens very high and then very quickly take them low. And we want to go to a castrate level. And this is a difference with propionate and cypionate. Cypionate will never get down to a castrate level. It will just slowly decay and never get down. It always be in a bad zone here and never get down to castrate level. So it doesn't really work very well on hormone sensitive guys. And it's not going to work to true efficiency. I don't think we're ever going to see it with cypionate. And here's an example I just plucked out. This is conventional knowledge. I'm sure a lot of you guys know this. And here's hormone sensitive cells, L cap cells, hormone sensitive on ADT. And you can see the growth is the viable cells, or the growth is very low. It's maintained control, but eventually we do this long enough, they're going to take off. And the reason they're going to take off is because they're upregulating to become B's, C's, and D cells. They start upregulating androgen receptors and mutating them, and they start to take off again and thrive in that environment. And we can see the castrate-resistant cells, which are LN-cap plus 80, or the LN-cap, actually, no, so they just have PC3 cells on here. The PC3 cells are the androgen-insensitive cells, and those are not controlled at all. Oh, and if anybody has any questions at any time, just jump in. You don't have to wait till the very end to ask a question. The hormone sensitive to CRPC time and the bad application to it, you're looking at SPA is going to inhibit, in cell studies have shown this, and we've seen this in clinical trials. One clinical trial was done on hormone sensitive men. I don't know if that's put out there very much. It's called Batman, hence the opening slide, Batman. The truth is that the mask is unveiled. The type A cells are going to be inhibited about 20-21% in 3 days of superphysiological level of DHT. And the LN caps, or the the CRP cells, some of them are going to be inhibited 31%, 32%, 38% higher or greater than. I mean, these numbers are in 3 days with a certain level of DHT, but they're going to be inhibited more than the HSPC cells. But some CRP cells are not going to be inhibited at all. And then what we need to remember is, let's see. Okay, what we need to remember is there's actually 2 phases here. So you're going to eventually, you're going to drop down to your ADT level, then your HSPC cells are going to be inhibited greatly. And your CRPC cells, as we know, are not inhibited much at all. Androgen sensitive cells are not inhibited at all. And one of the known mechanisms of BAT, and this is another issue with the CRPC only being helpful with CRPC. One of the mechanisms is it upregulates ARs, ADT upregulates ARs, and then BAT, superphysical androgen SPA, downregulates them, causes a downregulation. So they become sort of like HSPC cells, but BAT continues to work for many men. So that's so we're not seeing a failure due to people going HSPC. We're seeing a failure when androgen insensitive cells appear, and those are CRPC cells, or not HSPC cells. So hormone sensitivity, I strongly believe it's the time to start. And in my personal experience, I'm hormone sensitive. I'm still hormone sensitive. It's been 5 years, or almost 5 years now. When I started BAT, my PSA about 1.5 years ago, or almost 2 years ago now, my PSA was 0.17. It was slowly rising. And after 16 months, my PSA was 0.02. So my experience doesn't tell me that it doesn't work for HSPC men. In its present form with cypionate, I feel that might be true, but if we use propionate or darolutamide or extend the cycles, we don't have to have the same conditions or constraints on it. And then another thing I have always questioned, we do not know where the transition lies between HSPC turning into castrate-resistant cells. It's not a digital event, it's an analog event. And I put a little chart down here showing this is pretty crude, this is an exponential. I don't think that in actuality it's a true exponential, but this is a depiction. Your castrate-resistant cells increase over time, and your hormones on ADT, and your hormone-sensitive cells decrease. And do we apply BAT as optimum time here, or here, or here? We don't know. There's no trial that's ever gone into what's the optimum time. As you can see, it'd be pretty difficult to do.
Russ, I've got a question.
Sure.
Isn't Demean saying that everything that he doesn't want people that are hormone sensitive doing BAT, right?
He does not. No, I don't agree. I don't agree.
You don't agree with him, or was I wrong?
So I don't agree with him on that. Okay. On the next slide here, these statements. So the statements bullet 4. Yep. Those were made by Dan Mead. First of all,
and his colleague that spoke to us last week.
Antona Rockus. Yeah. Antona Rockus he works with Dan Mead.
Neither one of them wanted castrate sensitive men. They all want to castrate. If you were castrate sensitive, they didn't want you to do it, as I understood it.
Yes, that is their opinion.
Yeah.
And Dan Mead made a comment years ago, actually a few years ago. He was in an interview. He said the reason he chose castrate resistant rather than hormone sensitive was because the bar to approval was easier. He did not mention efficacy. He did not talk about whether it works or doesn't work. I don't think he would have made that statement if he knew that it's never going to work for hormone sensitive men. Another thing he said recently he said recently, he said BAT may or may not might be effective for HSPC men when he was questioned about the Batman trial, which is hormone sensitive trial. He said, but the focus is on CRPC. Our focus is on CRPC at this point in time. Those are not. I think a lot of his statements are politically driven and motivated by getting into this year, getting this approved. Very likely getting it approved for the standard of care. And if you're trying to get something approved for standard of care, we have lots of options for hormone sensitive guys. Or we have ADT, which we know works well for a couple of years. Eventually, it stops working, and that's a problem with it. Castrate resistance, we don't have as many good options. And the longer it goes, the worse our options, or the fewer options we have. And he acknowledges that, and I believe that's why he's trying to get into the castrate resistant space, or why he said he was. And with cypionate, we'll go over that in a minute here. With cypionate, you're never going down to a true castrate level, so hormone ablation level. And because of that, I don't know if cypionate is ever going to work optimally on hormone sensitive men. What they did do, though, about 7 years ago, they did a trial called Batman, and it was on hormone sensitive men, and they had really good results. Overall survival, average survival was over 7 years. That's pretty decent for a monotherapy. This is a monotherapy. That's another thing they're looking at is if you remember the presentation by Natona Rakis, I asked him about, well, if we use sequential therapies or combination therapies, is that potentially an in? And he said, yes, it is very much a very good possibility, because right now what the FDA is looking at and what's been pursued so far is using BAT as a monotherapy. And I don't know if we're going to see as a monotherapy, it's going to be accepted at SOC. I think that the most we're going to see is, like Antonio Rocca said, we're going to see it can be equivalent to other monotherapies, but not necessarily better. The quality of life, though, is going to be far improved. And if we look at it in sequence, like with Xtandi, using BAT to failure and then using Xtandi, we see massive improvements. But it's a sequential therapy. It's not. We don't see the same improvements as a monotherapy. Moving on to this will help clarify your question or answer your question. If you look at the Batman clinical trial, it worked fantastic, and it was on hormone sensitive men. What they did is they interleaved BAT 3 cycles of testosterone cypionate monthly with 3 months of ADT. And that is a very telling stat there. These BAT and ADT. So you can see here, we're doing BAT, cypionate BAT. We're not getting down very low in testosterone. It gets down to about 150. Some guys gets down to 100. Some guys only 175, 200. But then by going off that entirely, going off the cypionate entirely for 3 months, we get down to a true castrate level. And at that point in time, we are getting real control of these hormone sensitive men. So this is one option that could be pursued. If you're hormone sensitive, you could follow a scheme like the Batman trial. That's going to work very well, and did work very well. There's other ways you could do it, but this is one of them. This is a good way. Did that answer your question?
I think so, because what I'm trying to figure out is, it seems to be when it's presented by people when I've heard about it, it's like BAT right now gets presented as a Hail Mary when everything else fails for castrate resistant men. And it doesn't get presented as a monotherapy or as the Batman is presented. You don't hear about it,
Yeah, I think that's mostly the MOs who are presenting it. I believe it's
that's right.
Political. Yeah, they're trying to get into the castrate resistant space. They're trying to get approved for that. And right now, if you look at Batman, for example, One thing that's missing from this equation, we're not really discussing quality of life. The quality of life, libido, muscle, bone health, mental health are very much improved with that. So even if the efficacy is the same as ADT, for example, Batman, if even it turned out to be as the same as ADT, I think we have evidence it's better, or the performance of Batman was better. But if it was the same, you have to look at the quality of life aspect too, and say, well, which would you want to, which do you prefer? ADT, no libido, muscle loss, fat gain, and bone loss, and hot flashes, versus using BAT, which doesn't have the same issues and can reverse some of those issues. With the exception, it does add, or it does potentially with your hot flashes. You're going to have the same hot flashes when you go down in low and very castrate levels here. Other than that, you have to look at it and say, well, what do I want to do? Do I want to, if I have option A, which is going to last, say, 10 years, and option B, which is going to last for 10 years. Either way, I can live for 10 years. Option A, I live healthy, happy 50% of the time, and maybe not so happy 50% of the time, versus option B, where I'm pretty much miserable 100% of the time. Which do you pick? I think the choice is pretty clear. Or for myself anyway, the choice is clear. I'm going to pick the one where I feel better for 50% of the time. And if we look at bone health and muscle health, those are very highly correlated with prostate cancer mortality and progression. If we look at those two aspects in addition, we see that we're not only going to have better results, or maybe we have the same results from the prostate cancer aspect, but we're going to have better results from cardiac risk, from fracture risk, from the muscle, the sarcopenia risk. We have better results from other risk factors. So I'm looking at that and saying, I'm going to feel better for half the time, and I'm going to live just as long. And I think what we're seeing you can live longer with it. But I'm going to live just as long. That's been proven. I'm going to live just as long, but I'm going to feel better during it, and I'm going to reduce my risk factors from other health issues.
Okay. Thank you.
Russ,
Sure.
I know that we need to move on. I see you've got like 20 slides. I'm going to just slip in one quick question here, though.
Okay. Oh, and by the way, I'm willing to stay as long as it's needed.
Awesome. Thank you. For those that are considering BAT in a hormone sensitive setting, do you have any data that would help patients understand those that are better qualified for it versus those that are not? So, for example, in castration resistant, we're looking at high AR, we're looking at TP53, we're looking at BRCA2. Any leading indicators for patients that are in hormone sensitive setting that they will respond better than others?
I unfortunately do not know of any.
Yeah. Okay. Yeah.
Castrate, as you say, castrate resistance, we have a lot of data. We do have the Batman data we can look at and say, in general, this is our performance with the HSPC men, but I know what you're asking for, and it makes sense, logical. You want to see, well, who's going to be on that top end of the longevity curve, and who gets the most benefit and who gets the least benefit. And I don't think we have that data for HSPC. They're really doing a lot of the trials and studies and focus on the CRPC space. And so we have a lot of data on CRPC, and that's only recently coming out too. They're really kind of, they're trying to flesh it out now, specifically who is going to benefit and who isn't. And none of that work has been done in the HSPC space.
Okay.
As far as.
Yep. All right. Yep. It's an opportunity.
It's an opportunity, definitely. Certainly a big opportunity. Why did I respond? I'd love to know why I responded. It's it'd be nice to know. For me, it'd be 20/20 hindsight, but it could help a lot of others.
Are you TP53? Do you have TP53?
I do not have any mutations whatsoever.
Ah, interesting.
No, nothing's been Tempus originally on my original biopsy. In my original surgery, Tempus picked up some mutations, but Guardant CDX, and I've had some other genomic tests. There's supposedly no mutations now. And MSI is low. Tumor metabolic burden has been dropping according to Guardant, and now they dropped it up the chart. And I'd have to ask the last test, and I have to ask my MO what that means. Maybe it jumped up so high they said we don't want to scare them to death. I don't know.
All right.
Find out.
Okay, cool. All right. Thanks so much.
Sure.
I want to move it's a different wavelength off of the science and more on the access to this. And so, Russ, what kind of relationship do you have with your oncologist? How do you get them? Because I'm like, I could be sitting in many of the people here's shoes and say, I buy everything. You're running experiments on yourself. You have a model and a theory for why it's doing what it's doing and why, you know, you're able to tune it, and it's wonderful. And I want that too. But then, and sort of along the lines of what Brian was saying, what evidence is there? Because a typical oncologist is going to want research results or something. So how do you persuade
your oncologist?
Yeah.
Very good question. Very good question. My oncologist, I have a good relationship with her. I've known her for over 4.5 years now. And she has watched me do these different things starting with an estrogen patches, high estrogen. She didn't think it'd work, and it worked fine, worked really good. And so she, after that experiment and 2 others that I did, she just doesn't say nay to anything I suggest or what I want to try. But more to your point, realistically, like what do you do with an MO is not necessarily as lenient as mine. For the CRPC space, I believe we do have fairly good data on that, very, very high level data. And Denmead, other MOs are willing to talk to your MO, a person's MO who wants to do that, and guide their MOs through it. So for there, we have some definite resources, or some resources, and I think that it's going to be should be simpler to convince an MO to oversee BAT than if you're hormone sensitive. Hormone sensitive, we don't have the resources necessarily and the research to support it. And I don't think you can go into your MO and say, yeah, Russ Hollyer said this, therefore it's going to fly. I think they're just going to kind of laugh you out of their office. So what I do with HSP, with my BAT program, I get drugs from my NMD, my naturopathic medical doctor. I tell them what I want and why. And then I don't have a problem going to the black market and getting drugs in the black market. I've done that for decades, and I'm okay with doing that. And it's kind of interesting as a side. I am more comfortable, and when I've tested drugs that I get from certain black market pharmaceutical companies and manufacturers, I've tested them, and they're the goods. They're always the goods every time I test them. The only time when I've had problems is when I get drugs, on occasion, when I get drugs from compounding pharmacies, FDA regulated compounding pharmacies, or just brick and mortar pharmacies like your Fry's or whatever. There I've actually had a few problems. I found the drugs are not quite what was advertised. I don't know if they've been tainted, if it's a bad lot. I'm not sure. Maybe it's just coincidence for me.
So that leads to another just category of questions, which is, you're a citizen scientist. You're a role model for people that are going to be actively engaged in their care. You're almost like the extreme version of someone who's really taken full responsibility for their care. And your oncologist is sort of following your lead. You're not the co-pilot, you're the pilot. And that's very amazing. What gives you the confidence to do that? What is your background? Like you were saying, like, who's Russ Hollyer and why is he willing to go out on a limb and just sort of work his own, personalize his treatment and figure out what's working for him and run experiments on himself?
I hear you. I've always been, I'm an electrical engineer. did pretty well, work for a medical company, did fairly well in the field. Had a lot of experience with dealing with the FDA, and that's pretty much what my job was, doing interfacing with the FDA and quality screening and data analysis. And along the way, I picked up a lot of tools for analyzing data and looking into biology and working on medical products, not necessarily cancer related, but it wasn't that difficult to segue into cancer. I also, over the years, over 4 decades, I have been interested in hormones. And I'll get my computer before it dies. I've been interested in hormones, and that also because prostate cancer is a hormonal cancer, one of the few that we know of, breast cancer being another one. It has become fairly has facilitated my experience with or my comfort level with dealing with a hormonal cancer. 5 years ago, when I started talking to doctors about ADT and found out what was involved with it, this plays into it. I was told to do GnRH. Actually, the doctors didn't even tell me it was a GnRH agonist or antagonist. They didn't say anything. They just said, you have to do Lupron. So I looked into Lupron and I said, okay, this is bone risk, and obviously you're taking your estrogen down to 0 along with your testosterone. So, when I started talking to doctors about using estrogen, high dose estrogen, which I pretty much knew was going to drop my testosterone down to 0, I had a friend who did it, and I looked into the biology, and I understood, okay, this is gonna work. What I found is that I talked to 4 different MOs. None of them thought it would work, that it would reduce. 3 of them thought it wouldn't reduce my testosterone. The 4th one thought it would reduce it, but maybe not enough. Those were her words. I think it's going to reduce your testosterone, but it might not. My fear is it might not do it well enough. So, okay, that's very understandable. And she's my girl. She's been my MO ever since, because she actually understood a little bit about the hormones. So I very early on came to the conclusion that, gee whiz, when it comes to a lot of biology here, I picked some bad MOs to talk to. 2 of them are at the Mayo Clinic, though. And maybe I picked some poor examples, but they don't seem to know much more than me. And so in this case, they don't quite know what I feel that I know. So I was comfortable in doing it. And I also have a lot of test experience in my background, test quality screening, test experience. And I'm very comfortable with testing things out on myself, or testing in general, and looking at the results and applying the results. And I'm fairly comfortable with looking at different trials, and maybe I have to test things 3 or 4 times and get a nice standard deviation, get some confidence levels in this. Does that answer your question?
It does. Can you just, and maybe you'll come to this in your presentation, but just picking up on that last point, what are the tests that you're using that give you confidence you're keeping in the guardrails? You're not risking your health, and you're in a safe zone. What are the tests that you are using to monitor your progress?
The very crude one is PSA. PSA, I can test it in the same hormonal environment. Number one, androgens stimulate PSA, overexpress it, and lack of androgens, or Xtandi, for example, will underexpress it by about 90%. But I will test PSA in the same environment. If you test in the same hormonal environment, like towards the end of a cycle or at the start of a cycle, I like to do the end of the cycle, so it's low. You get a good feel for how PSA or KLK3 is expressing itself over time. But what I do when my insurance will allow me to, which I believe is once every 6 months, I do a PSMA PET scan. And that really gives me more proof of what's going on. And I believe it's once every 3 months they will allow a garden test, a 360 CDX test, which is nice. So then I can keep track of my mutations, my tumor metabolic load, our burden, MSI status. They don't give me any analog results. I suspect, I'm going to talk to my MO about that, but I suspect the reason why I don't get any analog results is simply because there's not much to see. I've gone under the radar, so to speak, at this point in time. There's not much to check. But those are the 3 tests. And I look at blood tests, CMP, CBC, and look at my liver trends over time, kidneys, kidney health, hematocrit, various parameters, but mostly PSMA PET scans. That's the biggest.
And this testosterone, like on this slide that you have up here, they're tracking testosterone or androgen. Is that just a blood test you're getting every week, or how does that work?
What I've done is okay. So with testosterone and the androgenic levels of it, we can calculate from the half-life and the decay time and the bioavailability of it, and we can calculate what your serum testosterone levels are going to be. Hypothetically, we calculate those, and we've done they've done lots of trials and experiments and studies over the years too. So, but then what I did is these are hypothetical levels. But what I have done, this is using cypionate, and what I have done for 2 years, I used cypionate for my constant high testosterone. I counted up one time, I think it was once every month approximately. It was about 24 or 25 measurements. And they all correlated. I could tell my MO. It's kind of interesting. I tell my MO, I haven't measured. I just took my testosterone test, had it measured yesterday, don't have the results back. They're going to be about 1825. And they'd be 1830 or 1815. It should be like, what the heck? How did you know? Well, okay, theory and based on my test results over the years, and everybody's a little bit different, so we just adjust the curve slightly. But these curves are pretty darn close to what you're going to see. And what I like to do too is I've not only taken these points, a couple points in here, so I can get the half-life down for myself and how high the peaks are for propionate and cypionate and androgel. I also measure a few times down here to make sure that I actually am going to this nice low level. And that tells me that Lupron, in my case, some ADT is effective. That my own body's testosterone is not gumming up the works. If you produce testosterone, that's something that's important to remember. You're always going to have to be on Lupron or be taking Orgovix. Take Orgovix and make sure it's active in your system when you're on BAT. When you're on BAT. If you don't do that, your body's testosterone is going to take over. And if your body testosterone is 500, you're going to see this curve go down only 500 here.
Can you use estrogen for the?
I used estrogen I originally used estrogen, high dose estrogen for ADT to reduce my testosterone to 0. It doesn't play well with BAT. And the reason why it doesn't work well with BAT is because, well, it only takes about a week to wash out of your system, so that probably be fine. But it takes about 3-4 weeks to drop your testosterone down to 0. And we don't want our testosterone and our estrogen to be high at the same time. There's Friedman is coming up to speak. You're going to be speaking to us in the coming weeks. And he's done a lot of research in that area, and he adamantly will say you do not want your estrogen and testosterone to be high at the same time. And based on that, the high estrogen, which would be great, I'd love to use it, but I can't use it with BAT. So I use it for standalone ADT. Haven't used it since. I use a low dose estrogen though. Replace it. I'm not worried about dropping my testosterone down with it. I use low dose. I started replacing, say somewhere over week 4, or I'm sorry, month 4. On this curve. I'm not doing this particular one, but on this curve, I'd replace about month 4 and then continue until right about the end, a week before month 8, where I'm going to pop up my testosterone again.
Okay.
But high dose estrogen works very well for ADT. Very well. I would use high dose estrogen any
So
day
you
of the
would
week
you could
versus
stay on high dose estrogen for your ADT until you appear to be approaching castrate resistance, and then you could transfer to BAT, but you'd have to use a different ADT drug. You couldn't use high dose estrogen at that point.
Correct.
Okay. 'Cause, 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 'cause,
One thing that my MO and I did, and this was her suggestion, I was thinking it, but it was actually her suggestion. I was surprised. We monitored my testosterone at first. I didn't get a Lupron shot for the first 3 months of BAT, or actually I started with Firmagon, but you're here or there, same thing pretty much, except the agonist, antagonist, but the same net result. My testosterone doesn't recover right after it's been suppressed for a long enough time, and especially Lupron, it's going to take months to recover. I was doing high dose testosterone, so my endogenous or my body's testosterone was shut off, and when I stopped and started BAT, she said, we don't want to, you don't have to do any shots now for ADT. How about we just monitor your testosterone? I said, okay, that's great. Thank you. So if you're doing high dose estrogen right now, you might be able to just, when you go off of estrogen, you might be able to monitor it for a while before you start to worry about doing Lupron shots or Firmagon or Orgovix. I think Orgovix is going to be the best working one. It's oral.
That's an oral pill, right?
Yeah, it's oral. And I think it's gonna be the best one. You could it drops your testosterone down pretty quickly too, and your testosterone recovers fast after you're done. It's a fairly short half-life, and I think it's good. I think you could actually work with not using it full time on BAT. You could just use it when you want your testosterone to be 0 or very low.
Okay.
I don't think it's going to be a problem though, because you are controlling your testosterone exogenously through your shots. And I don't think there's going to be a problem having your body testosterone. Actually, no, it shouldn't be any issue. It will not be any issue whatsoever to have it low all the time. And that's what they're doing in trials right now. What they've been doing in clinical studies. Take Lupron continuously and just change the exogenous testosterone, control your testosterone levels by your exogenous shots. Your muscular shots or your androgel applications.
So Russ, I just want to do a quick time check. I know some folks may have to drop off at the top of the hour, and I want to make sure you get a chance to get through all of your material. Are we getting pretty close?
Let's see. I think I have. Yeah. What would you guys like to? What do you guys like to see? Yeah, I have a few more slides, or some are kind of backup now.
Yeah,
if people want to talk about specific things. This is when do you apply BAT? You can do HSPC, man. I really believe that is going to be the best time, the optimum time to do it. You could do it in early CRPC. That's not going to be a bad time, and that's what they're trying to do conventionally. You could possibly do it middle or late CRPC, but you're going to have to worry about some conditions. Disqualifiers, these are the conditions. Symptomatic bone pain. If you have symptomatic bone pain, you could make the pain worse. I believe there's a way to check it out, though. You could use androgel, a very short burst of androgel. It goes to your system in a day or two. You don't have to wait for 5 weeks for cypionate. You're going to see if you have bone pain, if you can handle it. If you can handle it, the bone pain, by the way, is not from cancer; it's from inflammation factors. Denmead will say that he's correct. It's from inflammation factors, not cancer. If you have bone mets, so they're threatening to make a fracture or really close to the spinal cord, those can be problematic, and you might not want to exacerbate those whatsoever, because you could get some cancer growth, and then you're going to get regression. But in the meantime, when you get the growth, then you you have a fracture or a spinal cord rupture.
So just a point on that, Russ, is that if you have soft tissue mets only, you're not going to feel a lot of this. I'm a case in point. I have just one bone met. I felt it a little bit in my pelvis, but I didn't really feel it anywhere else. So
you shouldn't feel it. You shouldn't feel it. However, I still think the best thing to do would just be to get some androgel. It's available at pretty much any local pharmacy. Get your doctor to write a prescription for androgel. Tell them what you're going to do, and try androgel, 1 dose of it or a couple doses, and 400 milligrams of androgel, and you're going to be able to see that that pain, if you have pain, and if you can withstand it. And if you can't withstand it with cypionate, if you did cypionate again 5 weeks, you got to wait a while for it to clear out. Androgel, couple days, and boom, there it goes. Yep. So I think that's the smart way to that's the approach that I would use. I didn't have any meds, but that's what I would do.
Yep.
But no, you should, to answer your question, no, you shouldn't have pain though. Says you have lymph node. Yeah, you don't have bone mets. The genetic determinants of that response, we know that HR or HRD or HRR mutations like BRCA2, TP53, TP53, and BRCA2, BARD1, here's a list. And I'm going to publish these slides so you guys can see them. Those all have very good responses to BAT, about 68% PSA response. Any PSA reduction, I'm looking at any PSA reduction is good. I don't always look at the 50% mark that we like to see, they like to see in clinical trials. That's fine, but I'm looking at that as if I can use it for 2 years and I don't get any progress of cancer, and I have my PSA actually goes down a little bit or even stays the same, I'm saying, okay, that's a win. That's 2 extra years of life and good life.
Yep.
And if you have a tumor suppressor loss, you had about a 54%. These are from trials, 54% PSA response rate. And things that, there we androgel, 300 milligrams, 400 milligrams of androgel. If you have any pain, androgel is going to wash out. If you have muscle pain, I know a couple guys in here had muscle pain. Number one, I think it might be from cypionate and it wouldn't be from propionate. But if you use ibuprofen or Aleve, those will very likely wipe out that pain, as Anton Rockus mentioned. Aleve, though, the problem with ibuprofen and Motrin is they're very short half-life. So you're going to have to dose up multiple times during a day, over and over and over and over, every 3-4 hours. Aleve has like a 12-20 hour half-life. You might dose once or twice a day. It's gonna be a lot easier to be taking Aleve rather than you're going to have to take a lot less of it than with ibuprofen or Motrin. If it works
For those that have kidney issues, you have to be careful with Motrin, Aleve, drugs. So just a warning.
Okay.
A warning there.
Okay. Thank you.
Yep.
Good note of that.
That just came from my nephrologist just this week. So because I've got a kidney challenge now. So
okay, thanks. I'll take note of that. Thanks.
Yep.
So, and something to remember, which Anton Rock has pointed out a little bit, is PSA might go up for a couple months. In fact, your cancer scans might show that the cancer is growing for a couple months, but that doesn't necessarily mean that's not working. That frequently takes a few months to start working for your PSA to go down. That's the real conundrum there, is when your PSA though is rising and your PSMA PET scans are looking worse. Then what do you do? Even after a few months, well, it might reverse itself, but it might not. So that's where you're going to have to look at your clinical symptoms. You talk to your MO and do maybe a personal search, decide if you're willing to take the risk of staying on it or not. And I don't think anybody would blame you. I know I would probably check it out at that point. If everything was looking worse in 3 months, I'd maybe just, okay, I'm going to cut out and try something else. This is how I perform BAT. I use Lupron continuously. That takes away my body's testosterone. I use propionate injections to maintain the high level. And then what I do, these optional drugs here, I do pretty much all of these. I use cabergoline to reduce prolactin. And that I think is particularly important for castrate-resistant men, but as far as I know, it has not been clinical trialed. It's a lot of studies. A lot of studies have shown that prolactin reduces your castrate-resistant overall survival. And then what I do, I use letrozole or an aromatase inhibitor to reduce tumoral estrogen and any estrogens converted from testosterone. But then I replace a little bit of estrogen, but it's systemic estrogen. It's not intratumoral estrogen. It's this over estrogen with estrogen patches, low dose estrogen patches when my testosterone is low. And then I use NPP, that's an anabolic steroid, for any kind of joint pains. So I feel really good on the high testosterone phase. And on the ADT phase, I use SARMs, selective androgen receptor modulators, like RAD140. It's the one I prefer. That's to maintain kind of a weakish anabolic environment so that I don't see all my muscles and bone, everything go in a bad direction, and I have a little bit of life left while I'm waiting for the next high testosterone phase. And then based on animal research and cell research, I introduce a couple short spikes of SPA, high androgens. And you can't really do that with cypionate. That's propionate, you can do it, but even then you have to monkey around with darolutamide or something for a day. Or you can space out the spikes by say a week or more, and then you're going to go to zero. Your testosterone goes to zero. And during SPA, I use finasteride on occasion. Finasteride is going to block DHT, the conversion of testosterone to DHT. It increases the testosterone action on the membrane androgen receptors. Really getting into the weeds there. That has not been proven. That's a lot of speculation, but it's good enough evidence that I still try it. I still use it once in a while. And Zytiga is going to block that intratumoral biosynthesis of testosterone and androgens, and also any adrenal, and it will block the testicular production too. But I'm using Lupron for that. But Zytiga, I believe, is a very good idea, and I think we're going to find that out going into the future. That Zytiga, we should have been doing that with Zytiga all along. And right now, I'm always doing experiments. I'm looking into how olaparib plays with that. I did a short pulse of olaparib. I don't think we need to use it continuously. I think maybe a 3 or 4 day pulse. Start one day before your high testosterone spike. Continue for 3 days after. Your DNA double strand breaks. If they're not repaired within 2-3 days, apoptosis occurs. So I don't think we're going to need to use olaparib for a PARP inhibitor for a long time. I think just surrounding that pulse. And there's also darolutamide or Xtandi. Those increase DNA double strand breaks too. So I plan to use it right at the end of my cycle, my high testosterone cycle I'm on right now, for 3 or 4 days to again, hopefully synergize with the DNA double strand breaks and prevent repair, NHEJ repair, and non-homologous in-joining repair. I have things shuttle down to the HR repair path, which should be swamped out. There's 2 types of repair for DNA double strand breaks, and if neither of them works, death of cancer cells, not of us. And I'm looking at a lot of other possibilities. And right now, I have as of this morning, I had 32 backup plans. Maybe 25 of them involved BAT or SPA, and in large part, it's because I feel some of them are just BAT synergistic programs with BAT, bipolar androgen therapy. But a lot of them are, I want to add the SPA pulses in so I feel good. And I know it may or may not actually, like radioligand therapy. Radiotherapy, I believe BAT's going to work very well with. Radioligand therapy, it might not. There's a reason it can, and there's a reason it won't. Let's see. Okay, so here's a list of some clinical trials: PARP inhibitors, immunotherapy, carboplatin. We're doing a trial on carboplatin right now. It's supposed to be out this year. Some of these guys clinical trials are notoriously late, but they're doing a trial called XBAT with BAT and darolutamide interleaved. That'll be interesting. And in 2026, this is a big one. This is a really important one. They're doing the step-up trial. And they're going to look at, doing the step-up trial, they're going to look at how Xtandi performs with BAT. If BAT can resensitize us to Xtandi over and over and over and over. If it can resensitize us ad infinitum, prostate cancer, if you catch it at the early castrate-resistant phase or the hormone sensitive phase, prostate cancer becomes like diabetes. It's a manageable disease that you just live with. It requires a little more than diabetes for the treatment. I don't know, arguably, but you die with it. You don't die from it. I'm sorry.
Who's running this one? Do you know?
The
lead,
step-up trial. Denmead is the overall. He's the leader of the trial. The step-up trial. The step-up trial came out of his Restore and Transformer trials. So he saw the Restore and Transformer. He saw some really interesting things with Xtandi and resensitization. And now he's going to try, based on that, he's saying, hey, he said in interviews, hey, I'm not sure how many times we can do this. We don't really know. We might be able to do this over and over and over. There's no reason why we can't, that he can think of that we can't. And if he's right, and step-up trial approaches, if their approach works, wow, we have a whole new ball game. And I think I would assume, I would hope that, and step-up trial is like 300-400 people. It's a pretty large trial, or 200 over 200 people. I would hope that the FDA is going to fast track that at that point if the step-up trial is successful, because we're looking at a major improvement, a major game change. And there's another one, BAT-RAD, which is using radium-223. And I believe that if BAT should, the high testosterone pulses and androgen therapy should play in very well, very nicely with radiation therapies, or just conventional radiation therapies. I don't know about radioligand therapies quite as much. There's, again, a con and a pro. But BAT-RAD, if we see that successful, and again, we're likely, we have data now that says that androgen deprivation therapy and high testosterone spikes will synergize with the DNA double-strand breaks of radiation therapy. So if we can prove this out in a clinical trial, wow. I'd do it now, though. I wouldn't wait for the clinical trial to be out. I assume it's just going to tell us what we already know. But I think we're going to find these things. Zytiga, we're going to find that it's a really good thing when they ever get around to doing a trial of Zytiga. Hey, it's good for a couple weeks, used for a couple weeks after your SPA, after your testosterone spikes. And I think we're going to find eventually that very high testosterone pulses are good. I don't know when we're going to find this out, because right now we're using cypionate, and cypionate, you can't do these very easily. And very short testosterone pulses are very likely going to be proven out. Your DNA damage occurs 15 minutes. Genetic changes occur within 15 minutes. DNA damage occurs within 24 hours, 48 hours maybe at the most. If it's not repaired, boom, death. So I think we're going to find that short testosterone pulses are very handy too, very helpful too. But again, cypionate, we can't do these things. So you're going to have to look at propionate or androgel, and fortunately, they're doing some androgel trials right now, so that might open the door to they're doing more trials with androgel. Here's some data from the Restore trial. Here's if we do BAT and then retreat with Xtandi, you can see that the very nice efficacy of Xtandi at that point. Transformer, over 75% of men, CRPC men who had failed Zytiga and went through BAT and then Xtandi, had a response. And the responses were not minimal. For the most part, they were pretty good responses, and some of them lasted for years. If we look at the data from that the FDA originally looked at to approve Xtandi for CRPC men and hormone sensitive men, we're looking at about approximately operating twice as long, being effective in 3 times as many men, and being much more efficacious in the men that it does affect. If you apply it after BAT, and it just seems that this is something that I hope they're going to pursue in clinical trials to get an FDA approval. Again, using BAT as sequential therapy, not necessarily as totally as monotherapy. It's a step in. It should be a step in a therapeutic path. It should not be the only end. You can use it in combination with certain drugs. You can use it in sequential therapies. You can go back and use it after you use a Xtandi or a darolutamide. That's where I believe the real benefit is going to lie, and not necessarily as a monotherapy. The monotherapy is just, it's fantastic for quality of life, and you get the same overall survival, though. You don't really see an improvement there so much.
Hey, Russ, I'm just going to pause there for just a second. Brad, I know that we're just about well over a bit of an hour over our time. Maybe what we should do is, Russ, maybe if there's like one more slide that you want to present, what is like the key next slide, and then let the audience ask questions, because I'm sure that there's a lot of questions, and we want to make sure that people who are considering this or know people who are considering it are getting their questions answered. So one last slide, and then we'll turn it over to Q&A.
Okay, could I do 2 last slides? Actually,
Two.
scan these real quick.
Okay,
and
that's
then,
fine.
I'd be more than willing to come back and talk again too.
Yeah, I appreciate that.
Bone density. We talked a lot about bone density. Some guys have bone density issues. My bone density increased 5.20% in a year and a half. A DexaFit scan, which I had separately, I thought, boy, those numbers are crazy. DexaFit scan showed a 4% increase, but it actually measured more points, and so it was more accurate. And an overall bone mass increase of 4.8%. My liver enzymes has gone down. My white blood cells and red blood cells are holding about the same, surprisingly. There's my BAT results. If you can see that chart, here is when I had RP about 5 years ago. Then I did estrogens. I take an ADT, and then bicalutamide dutasteride, and then I use high testosterone constantly. This green area here, and then the blue area BAT. And my BAT, as you can see, my PSAs, which I did not measure every single high cycle, and I didn't measure testosterone every single high cycle. But my testosterone, or my PSA naters, sorry, have held about the same. They're very nice. They're lower today than what it was 2 years ago or a year and a half ago when I started. There's a blow up of that chart. Here's a list of clinical trials. And Denmead's willing to help anybody. And I included his contact info. And also his patient's guide to androgen therapy and bipolar androgen therapy, and then my contact info there. Here's cypionate very quickly. Cypionate will never drop down to the castrate levels. That's what I'm talking about. And here's propionate. Propionate drops down, boom, drops down very quickly. So we hold testosterone a lot higher for longer, and it drops down very quickly, very nicely. You could do cypionate for 7 weeks, which Tony Rockos was referring to. He was talking about 6 weeks, but I think 7 weeks, whatever, you do it for 6-7 weeks, so you're going to get a lower level there. And you can do a darolutamide, and then you can make it work. Here's what, and I think I'm about done. Any questions?
Okay. It's fine.